Hello and welcome. This is NTA Tuesday Live and I'm Cyril Stober. Tonight our focus is on National Health Facility Survey, prospects and challenges. The National Health Facility Survey, NHFS 2023, is a follow-up to the 2016 and 2019 surveys. The survey modified the Service Availability and Readiness Assessment, SARA, a standard health facility assessment methodology promoted by the World Health Organization. Now, the SARA is a systematic health facility assessment tool designed to assist countries in assessing health systems progress, monitoring service availability, and readiness to provide services at health facilities. Additionally, it incorporated service delivery indicators, SDIs, survey instruments developed by the World Bank in collaboration with the African Economic Research Consortium. Now, the SDIs aim to measure primary healthcare service delivery to improve the monitoring of service delivery, to increase accountability, good governance, and targeted intervention by assessing the quality and performance of health services from the citizen's perspective. Now, these tools have been adapted to meet the objectives for consistently monitoring the quality of care for the Federal Ministry of Health and Social Welfare, and to provide information needed to strengthen the health system and specific health services at state and national levels. Therefore, the 2023 NHFS covered the availability of basic inputs such as infrastructure and equipment provider effort and provider knowledge, which are key variables for assessing service delivery at health facilities. Well, that's all about what we're concentrating on tonight. But before we go into the conversation, let's get to see this report put together by health correspondent Uche Ugochukwu.
Nigeria's health sector, a lifeline for millions, is facing mounting pressure as evidence of dwindling resources, outdated equipment, and staffing shortages comes to light. The National Health Facility Survey aims to paint a clear picture of the state of healthcare delivery across the country, identifying challenges and mapping out opportunities for growth. The survey highlights critical gaps from malfunctioning diagnostic machines and insufficient medical supplies to overburdened healthcare workers. In rural areas, primary health centers struggle with limited electricity, lack of clean water, and inadequate staffing, leaving communities vulnerable. However, the survey also reveals pockets of excellence in some facilities. These success stories underline the potential for transformation if resources are allocated efficiently.
We have a solar light here, really, we don't have it. And when there is no solar, if there is no light, NEPA, so we used to on our solar system here. Really, we don't have it. Even now, it's a solar system that we are using here.
Experts say the survey's findings must serve as a wake-up call for policymakers. Recommendations include prioritizing budgetary allocation to healthcare, giving incentives for rural postings for health workers, and leveraging technology to improve service delivery.
Efforts have been made, but we need to work harder. We need more resources. We need more coordination and efficiency.
We continue to ensure that we rebuild our system based on the foundation of good quality primary care. And we will make sure that we build a health system that focuses on prevention, that focuses on primary care, and one that is fit for purpose and cost effective for Nigerians. But we also want a system where individuals are active agents of their own health. So health promotion, what the minister has mentioned, of the production of health in terms of lifestyle and looking at health holistically, is a system we want to build. NHIA will continue to be a partner in that process to ensure that we enhance financial access, and we continue to incentivize this focus on primary care, on prevention, and a holistic approach to healthcare.
As the data sparks nationwide conversations, the hope is for meaningful action that bridges the gaps in Nigeria's health sector, transforming it into a system that not only meets but exceeds the needs of its people. Uche Ugochukwu.
That report sets the tone for tonight's discussion. Let's start off by introducing our guests. We'd like to welcome to this program Dr. Muyaino. He's Executive Director, CEO, National Primary Healthcare Development Agency. Thanks for joining us tonight.
Good evening, Cyril. Happy to be here.
Right. Let me also introduce Dr. Chiemele Eze. He's a Doctor of Medicine, Global Healthcare Ambassador, founder of Talentscape International Medical Education and Career Academy, an advocate for the World Health Organization on universal health coverage. Dr. Eze, thanks for being here.
Thank you very much for having me, sir.
Right. Let me also welcome tonight Dr. Abolade Rajuddin. He's Assistant Director, NHFS Project Coordinator, the National Bureau of Statistics. Glad that you're here with us tonight.
Thank you, Steve, for having me here.
Okay. At some point in time, we hope to be joined by two other gentlemen via Zoom. We'll introduce them just as soon as we can get them up and running. But of course, as you know the nature of this program, at some point in time, yes, okay, on the split screen there, you can see on the left Dr. Nuhu Solomon Yegu. He is immediate past provost, College of Health Sciences and Technology, Ida, Kogi State, and a former Deputy National President, Environmental Health Officers Association of Nigeria. Well, next to him, a rather dark picture there, is Professor Samuel Oluokere, the Faculty of Clinical Sciences of Bafemi Awolowo University, Ile-Ife. And, he also joins us via Zoom. We'll try and adjust those pictures so we can see them clearly. But, gentlemen, thanks for joining us on this program tonight. We hope that the pictures will be clearer when we come to you to make your opening comments. As I said earlier, at some point in time, the program goes interactive. You can join in the conversation, but when it's that time, we'll remind you of the process and the procedure. For now, let's begin to look at the issues at stake. And easily, we've watched a report, and clearly, some issues stand out. The federal government is challenged by the outcome of the survey. Now, let's begin by asking, what's your take on that? We start off with Dr. Muyaino.
Thank you, Cyril. I think the findings of the survey are the findings of the survey. I think we trust the process that was taken, the methodology we're very familiar with, the institutions that conducted it are long-term partners, and we work with them to do this as a Federal Ministry of Health. So I think we take this survey very seriously. Now, it's part of a learning journey. What we did when we came in was try to set a baseline to understand the state of things when we are starting as a government and identify what the gaps are at multiple different levels. I think, and of course, over the past year that, and a little bit, that the Minister has been leading a team of different agencies, we have started to actually tackle some of these specific things, the gaps that we have found, and hopefully we can speak a little bit more. So just to be brief on that.
All right, thank you so much. We'll come back to you, but let's go to Dr. Chiemele Eze. Well, you've been working closely with the Federal Ministry of Health and the World Health Organization on universal health coverage. Well, looking at that report, what are your observations in terms of achieving national healthcare target?
Thank you very much, Sir Cyril. The findings of NHFS is actually a wake-up call. It has revealed many gaps in healthcare architecture in Nigeria, and we're happy that the reports are here. It shows that we're not where we should be, but that also means that it's a time for reflections to build up resilience, reflections that everyone will talk about the health and future with a view to understanding the universal health care coverage meant to come into view by 2030. So what that means is that in the next 5 years, this report is what we're looking at this moment, with a view to understanding how best we can meet up with needs, looking at the facility infrastructure, workforce shortage, and also, essentially speaking, looking at uneven distribution of healthcare, across, the states of the country. So what we are looking out for at this moment, how do we bridge these gaps? How do we actually come together, understanding that this should not be left in the hands of government alone? We should come together. It should be a collective effort to make the healthcare work in Nigeria. The individuals should see themselves as stakeholders, in as much as good number of corporate organizations, communities, etc. We should all come together to enable the national, interest or national ambition of universal health coverage to be a thing that can be actualized. Let's leave it at this. You know that we would continue to add more as we go on.
All right, in greater detail. But for Dr. Abaladis Rajuddin, why the focus on health care facilities?
Okay. If you look at your introduction, the tools that we made use of in assessing the facilities that were covered were the SARA tool, that is the Service Availability and Readiness Assessment tools. The essence of this tool is for it to be able to evaluate the current status of our health facility in terms of service delivery to the people. Is it adequate? If it is adequate, what kind of quality of care do they offer at these facilities? These are issues that was brought up.
Yeah, easily the question would be, just as you said, is it adequate? What are the gaps?
Okay. From the findings, if I will just share some of it, there are a lot of gaps. Like when we talk about availability of essential drugs in the primary health care centers, the statistics tells us about 34% of these primary health facilities have essential drugs available, while in the secondary facility, 50.6% has essential drugs. While if we look at the total facility combined, it's just 35%. So it shows that there's a lot of gaps. Then when it talks about availability of medical equipment in the primary facility, is just 29.9%, while the secondary is 68%. Now, when we look at the issue of reproductive and maternal, that is RMNCAH, the availability of family planning commodity in the public health facility for male condom is just 20.5% of the facility that have this, while if you talk about implant, it's just 17.8%. These are really low. Now, in terms of provision of antenatal care, is a bit higher in the secondary facility, which is 86.2, while it is 79.4 in there. But when you talk about delivery services is still a bit low in the primary health center. It's just 66.8. Then the one that is so dismaying to me personally is the visit of the postnatal care. For now, it is 17.5%, which is very low. It shows that there is a kind of possibly it might be attitudinal effect or cultural, or possibly it might be economical in terms of mothers going back for care after delivery. These are mind-blowing. Then when you talk about skill attendance in the facility, is very low in primary, it's just 11.4%. While it's 62% in all these. And then when you get to the issue of record keeping is still very low in most of the health facilities. When we talk about antenatal care record keeping, is as low as 11.1% in South-South. So these are issues and gaps that the survey was able to showcase to Nigeria.
We'll come to that, but let's take a peek at rural communities, Dr. Aino, and the state of facilities in them. If you're reading out this findings on the survey, what would you describe rural communities and the state of facilities in those communities?
I think that, thank you, Cyril, and thank you, Dr. Abolade, for that rundown. I think that, incidentally, when we also came in last year, one of the first things we did was to do a public primary health center focused assessment to try to understand the gaps and some of the attributes that are associated with the gaps. So we went through a process of figuring out what does it take for a primary health center to be fully functional, and we defined it to say it's a number of things. One is some of what you have mentioned in the report, but also in what Dr. Abdullah said, which is one, the infrastructure is decent enough, dignified enough that you and I can walk in to access services. Two is that they have a minimum complement of skilled bath attendants or health workers. You know, skilled baths is sort of a tracer service for other services. If you can take a delivery, chances are you can treat malaria and do basic diagnosis. The third thing is that you have the basic equipment and commodities to work. You have power that allows you to function 24 hours. Many times the deliveries happen at night. So part of why you see in many facilities that the deliveries are not happening in the health centers is that they don't have 24-hour power. So I will tell you some of the things we're doing about it. There's a drive to really push up solar powering of facilities, as you have seen. And I think the last part is also accommodation. And this is where your question about rural communities really comes in. That we find that to retain health workers in rural areas, there's a need to have accommodation for them so that they can stay there. Now, what did we find? We found that when you look at some subset, I believe the survey, the health facility survey that he spoke about, covers about 40,000 thereabout facilities, 33, a lot more. But you see, so there's a lot of facilities that operate at the primary health care level, but there is a subset called the Basic Healthcare Provision Fund Supported Facilities. As of today, there are 8,421 of them, really pushing towards one per ward. And over the next year, we will be doubling that number to 17,600, so that not in a 2 per ward arrangement, but to solve for some of the gaps that you are trying to touch on. When we looked at this first set of facilities, we found things that aren't too different from what the health facilities found. Now they do better because there's been some investment in them. So many of them, only about a fifth of them, 21% actually, met all of the criteria of full functionality. Now we know that the primary health centers are the bedrock of access to services in the rural communities. In the urban centers, there are private facilities, there are more secondary facilities, but only 1/5 of them. So the minister went to work under the mandate of the president, and we started to address some of these gaps in very specific ways that I will go into as time goes on. Yes.
Well, I just want to draw attention once more to some of the figures he's led us into, particularly that of postnatal care. 17% for a country that for decades been struggling with antenatal and postnatal morbidity. One would think that this by now should have been much higher. But he says it could be attitudinal, It could be cultural, these factors are there, and perhaps economic. And well, the economy is the way it is now would certainly contribute greatly to people staying away, or women staying away from postnatal care. And so is this part of what you're looking at?
Absolutely, Cyril. So last year, in December of 2023, Mr. President, President Bola Ahmed Tinubu signed a compact with all of the 36 governors and the coordinating minister for health, but also all of our major development partners, to really agree on a set of priorities that we will focus on as a health sector and really drive. And one of them, perhaps the most visible, is a rapid reduction of maternal mortality. We call it, we have a goal to crash maternal mortality in the short few years that we're here. And the reason is not far-fetched. Too many women die for trying to have a baby, which shouldn't be a cause of death. And part of it is some of the things that you are trying to. So there are a number of factors, we have looked into it, that are driving this. And it's a mix of all of what you've said. There's some supply side issues, which is some of the access issues, some of the quality issues, even when you do get to the facility. So when the facilities are not there, or when they're too far away, or in fact, when the skilled birth attendants are not there to take your delivery, or they don't have the equipment and the complement of commodities to give you the care that you need. That we are addressing, and I will speak more to it in a bit. Now, on the demand side, there are a number of things. I think there are pockets of communities where there are cultural issues, and what we're doing is community listening to try to understand the driver in each community. But also there are real issues around transportation. When the woman is pregnant or when they've just had a baby, if a facility is too far away and they don't have a car, they're living in rural areas with bad roads, they don't have public transportation, we know that it's very hard for them to get there, both in terms of just physically, but also from the financial outlay that relates to that. So the minister, actually, the coordinating minister, flagged off a program called MAMI, which is Maternal Mortality Reduction Initiative in Nigeria, when we did the joint annual review about a couple of months ago. And that is solving a number of things. We looked at the data from the NDHS to understand where the most deaths were happening of mothers. Because again, we know what to do, but you can't go everywhere at the same time because of limitation and resources. So we have identified the 172 local governments that account for 55%, more than half of all maternal deaths in Nigeria, at least based on the data that we have. And we have gone to drill down in a few of these to try to understand what you need to do. And there are a few things. One is we're prioritizing such locations for the investment in primary health centers as we're going forward. We are recruiting and deploying with incentives for retention health workers, skilled birth attendants, working with the state governments, to do that, so that for sustainability, so that they can recruit and we support them through the resources. We are buying commodities and deploying for each woman. The idea is that it will cost you nothing to access services from these facilities. The minister announced that MNCH, maternal care, is free. But beyond that, if you do need emergency obstetric care, emergency cesarean section, for every woman who gets emergency cesarean section in an accredited, NHIA accredited facility, is free. It's paid for by the program. Now, part of that is also the postnatal care. There are incentives that we're giving women to come, including vouchers to reimburse their transportation. The National Emergency Transport Gateway of the Basic Healthcare Provision Fund has also been reactivated. In fact, right now they're in the process of procuring and deploying little ambulances that will also prioritize the same locations that will be accessible. But in addition to that, they are setting up a framework to even outsource ambulance services and pay private providers, so that there's a network that if you have to transport a pregnant woman from her home to a facility From a facility to our home, it's a reimbursable service through a mechanism. So there are many things that we're doing, but I will pause.
Okay, all right. Well,
yes.
In addition to the discussion in the studio, we have other reports, and this one is from Maiduguri, Tina Toro.
Available data shows that Borno State, with a population of about 7 million people, comprises 22% females of childbearing age, 20% children under 5, with a fertility rate of 6.1%. These statistics has influenced decision-making in the health sector towards enhancing healthcare service delivery, expanding programs within the health system, addressing manpower deficit, amidst other challenges.
At any point in time, we have 400,000 women who are pregnant in Borno State. We have to plan for their drugs. We have to plan out of what percentage would need, cesarean section at any point in time. Also, those who have had any complications as a result of obstructed labor, and we should plan on how to remedy these problems.
The Governor Babagana Umar Zulum-led administration has rolled out healthcare programs focusing on maternal and child health by offering free cesarean section and delivery kits to pregnant women and free drugs to children from 0 to 5 years.
Despite Nigeria's enormous wealth, Nigeria is at the bottom 3 in the world and contributes 30% of maternal death in the world. And therefore, the government of Borno State has taken it very seriously, this issue. We're still recording 33% only in terms of delivery in our hospitals or healthcare institutions. And unfortunately, we continue to lose a lot of newborn children because they suffer from simple airway obstruction, often medically is called asphyxia, which we can easily treat in our healthcare facilities.
To address infrastructure deficit in the health sector suffered by the Boko Haram insurgency, the Borno State government has built new colleges of nursing in the northern and southern senatorial zones, in addition to existing ones, with primary healthcare facilities upgraded for efficient service delivery at the grassroots. Salaries of medical doctors have also been upgraded to be at par with their counterparts at the federal level, and scholarships for students of nursing to ensure adequate manpower for health.
These are all aimed at getting people who, manpower that can be able to, make sure services are provided to people in Borno State, and also take care of the Japa syndrome, so that even if some left for greener pastures, we still have enough to be able to, provide what is required for the people of Borno State.
Despite paucity of funds, a major challenge, the Borno State government is poised to availing its citizens with quality healthcare services. As post-insurgency recovery efforts continue, new strategies and innovations will continue to be deployed towards enhancing maternal and child health, building capacity of personnel, improving infrastructure, and increased public health education. In Maiduguri, Tina Toro.
All right, let's take this other one from Oka by Jane Francis Obi.
Maternal mortality and morbidity remain an important public health priority and are key indicators of women's health worldwide. Factors such as distance to facilities, poor quality prenatal and maternity care services, and lack of funds to engage health professionals, among others, are impediments to women and maternal health care. To record a substantial reduction in maternal mortality and morbidity, the Anambra State government has ensured a well-equipped primary health care centers in the 21 local government areas in the state and offered free antenatal care for pregnant women.
One of the review we did found that most of these women present very late to the hospital, so after delivering at home we are in a traditional birth area with consequent mortality or morbidity, as the case may be. So after we did that, we started this free delivery. The governor pronounced there's no one in Anambra State to deliver paying anything, and there's no one in Anambra State including any form cesarean section, normal delivery.
With this offer, many women in Anambra State are now accessing health care irrespective of their financial status.
They are giving treatment. So Governor Soludo used to provide drugs. we give them antenatal drugs, and it is given free of charge. Today is our antenatal. We have distributed it today to patients. Then even delivery. We have free deliveries in this hospital, free CS in this hospital.
It's been great. I am one of the beneficiaries. He made everything almost easier and possible for us, more especially in this difficult time.
I entered theater. They treat me normal. Even nurses, even doctors.
We didn't order any fee for us. We didn't say we should pay any fee.
However, to achieve zero casualties in maternal health care, efforts should be placed on long-term community health education, family planning, and women's empowerment, while skilled care before, during, and after childbirth should be improved on. In Oka, Jean Francis Obi.
Well, that report brought us the situation in some of the states, and that's where I'm coming to you on the efforts of subnationals. It's all right for the policies from the central government to be enunciated. And another thing, to see how the subnationals key into this project. Now, you have been working on universal health coverage. How would you assess? We've just seen two cases from two different parts of the country.
Very good. From what was shown from Oka, it's very evident that the governor is doing very well to ensure that maternal mortality or morbidity, as the case may be, it's being addressed, and he has provided a long-term solution, which I know that a lot of partners in Anambra would key in. We are trying to also ensure that the same thing would cross-fertilize to other states where development partners, where individuals who are well-meaning, the philanthropies could also come on board. It shouldn't be reserved in the hands of the government all alone. Subnationals, the corporate organizations, everyone should come on board to ensure that this long-standing solutions being provided by government would actually be a continuum of care. With what we also saw in Maiduguri, I think it's also a wake-up call, and it's also encouraging, because from what we saw there, the government is actually getting a lot of things on board with a view to making provisions that could be long-lasting. Now, the question is, sometimes this national healthcare facility survey would come right before us, and everyone would look at it, but most times it's usually in the hands of the experts. For the subnationals and other individuals to key in, we should make effort in enlightening the public on this document, telling them the implications of the decrease in virtually everything, ranging from equipment, workforce, even the essential services such as maternal care and immunization. Everything tended to be low, So we should enlighten the public, let them understand this, let this be a national discourse, because that is the first thing that should enable the subnationals and individuals to come on board. So by the time we would have these descriptions and enlightenment, you would now realize that we should now make the critical stakeholders to understand the implications. And from there, we take it to every individual in Nigeria, letting them know that they're all stakeholders in health, that health should not be reserved in the hands of healthcare professionals alone, but it should be for everyone. We all have right to life. We have right to health as well. So what that supposes to mean is that it should be health for all for health, and that's what we advocated. And this is one of the ways we can get the universal healthcare coverage, in the quickest of time. So by the time it becomes a national discourse, what else should we do? We should discuss it at everywhere, every forum, or every fora, as the case may be. So you now realize that it should be discussed at National Assembly, State Assembly. Let's make it sound like the Premier League. Let it be discussed on social media. Let everyone be aware and know the implications of not working, to ensure that this would not be replicating itself or be on the decline. So that being done, we would now ensure that we would get a platform where people can now, contribute, not money alone. A lot of people have suggestions on how best these things would work to be better than what we have got. Then again, you also realize that by the time people would keep contributing on social media, on different platforms, you would that would also ensure a long-term solution that could enable Nigeria, the Nigerian government, to now keep on advancing on what we've got as the record. So with this, I think by 2030, if all things being equal, we would also add this very quick one, that the budget is to come, but how much of these components can be implemented? How is it going to inform our decision making? How is it going to inform the policy making? The policy makers should look at this, to prioritize, what should come on board, because this has revealed the deficiencies, it has revealed the problems, and I want to believe that it's standardized. Having been done by Ministry of Health and Social Welfare, and also the Bureau of Statistics, one can actually believe that by also extending collaborations with international organizations, health initiatives, at different levels and from different parts of the world, we can now work together to ensure that the healthcare coverage, which is the ambition of the federal government of Nigeria, would actually become something very feasible by all of us playing a role. And I'm very happy that we have come here to discuss this fundamental truth, to discuss this particular course, that it's about our health and it's about the future, and every one of us should take it seriously. A country that does not take care of its health would have poor performance, poor productivity, and that would affect the nation building. So thank you very much, Cyril.
Okay. Well, we see at this point we're able to establish links with Dr. Nuhu Solomon Yegu, and if he's there, let's see if we can get him on. Establish links.
Thank you very much, Sir.
Right.
Good evening.
Yes, good evening.
Good evening. Yeah, good evening, sir. Yeah, good evening, sir.
Yes, good evening. Let's hear your inputs. Obviously, we've listened to the other speakers here.
Thank you. I think bringing up this very important issue on the national discourse is very important at this time, particularly now that we discover that disease burden is on the increase. The occurrence of diseases in the nation is becoming rampant, and when we assess the state of our health services, it is quite very low. In view of this, we have been emphasizing on the role of the critical stakeholders. It has always been commonly reported that the major indices with which we can measure the effectiveness of health services of any nation or state is a drastic reduction in the occurrence of diseases and, if possible, total elimination. Now, with the increase or with the rise of disease burden in the nation, with the mortality rate on the increase for our newborns under 5 and so on and so forth, and even the pregnant women, it raises a serious point of concern that we need to do a lot to improve our healthcare system. Now, from even the topic of this discussion, the challenges we have in our health sector today are very glaring. And doctors who are on the table for this discussion, they have highlighted so much. But I think a time has come, we need to move from highlighting on theories, principles of operations, to pragmatic approaches that will help to actually reduce the rate at which this is affecting the health of our nation. And in view of that, I am advocating that we should return back to what we used to do in those days, particularly before the introduction of primary healthcare delivery system in this country, when we were using the basic healthcare scheme. Now, the primary healthcare delivery system has been introduced in our healthcare system in the country with a view to make health services accessible, affordable to the people. But as of today, is this healthcare services still affordable? Is it accessible to our people? Now, we have health facilities, but these health facilities are having lots of challenges. The problem of brain drain in this country. Many of our health workers are moving to other countries of the world because of the lack of improved remuneration for health workers. Again, Our health facilities, there are health facilities you go today, you cannot even see 2 beds. And you may not be able to see 1 or 2 nurses. So it's a serious problem. And again, when you go to a health facility, for example, we're supposed to have different health professionals, nurses, doctors, pharmacists, pharmacy technicians, dental technologists, nutritionists, dietitians, and all other relevant health professionals. But these are not available. And what is the reason? The reason, again, can be traceable back to our health training institutions. The health training institutions in this country, like colleges of health sciences and technology, are being grossly neglected by government. In short, one most surprising thing is that government of this present day provide facilities for the different tertiary institutions in the country, but they classified health colleges as monotechnics, and for that the law now exclude them from this intervention of government. And that is why colleges of health sciences and technology, which is given back to by the introduction of primary health care in Nigeria, is being greatly neglected, and there are dearth of facilities in these institutions. And as a result of these, we can no longer train these different cadres of health professionals. If we're having hospitals and these professionals are not there, how effective will our services be? So these are things we need to look at very critically. In those days too, we have drugs that are made available in our health facilities. But as of today, are we having drugs available? You come to health facilities, you cannot access drugs that the people, the clients or the patients will make use of. So it's a very big challenge. Therefore, as government is trying to prioritize the issue of provision of healthcare services for the people, I want to advocate that the improved budgetary allocation of government should also take care of these areas.
Thank you so much. We'll ask you to hold on a while. Some of the issues you've raised here certainly attract comments from the studio here, but Dr. Mia, is about coming in here to speak on some of those issues.
I think the gentleman raised a number of important things, but I thought it's a good opportunity to share some of what the government of the day, the government of President Tinubu, is doing to address some of these things. Mm-hmm. So you talked about the dearth, the reduction, loss of our workforce due to exits and migrations out of this sector. In fact, what you will observe is that over the last year, the president declared that he wanted to do a number of things: increase the production, improve retention, re-attract those that have left, but also upskill the ones that are existing. Starting with the upskilling, over the last several months, in the first year, we had a 4-year target of 120,000 health workers trained. We have done 53,000 as of today, over the last several months alone. We trained them in integrated primary health services, including safe baths. We are now developing an e-learning module so that it takes less time. We don't have to take them away from their workforce. They can be more self-directed and learn at their pace. Now, you may also be aware that for many of the medical schools and nursing schools and schools of health tech, one of the first things that the minister did was to do the legwork to double their production capacity. One of the things you can do, you can't force people from moving and making decisions around their personal lives, but you can create environments that make things. You can produce more than you need, hopefully, but you can also provide environment. I spoke earlier about the fact that we're putting power in the facilities, we're putting accommodation, residents in all of the rural facilities, so that it's a bit easier on the health workers to do that. You did say also, you spoke about the infrastructure and the equipment in the facilities. I can tell you that in the last several months since we started this, a total of 309, as of when I counted yesterday, PHCs have been moved from subpar to what we're calling level 2 full functionality. Another 311 are currently being fixed directly by a federal government intervention. So we have contractors out in the field putting in the solar power and putting in solar boreholes, equipping these facilities even as we speak. But I also tell you that within the next year, before the end of 2024, the states already have resources with them that, you know, the federal government worked with the states to mobilize through World Bank financing to add another 3,018 PHCs to that level. So money will get you the infrastructure, to get you the equipment and the commodities, the tools and the drugs and commodities that you need. But also we're doing a lot on the workforce. Part of that, like I said, is increasing the production. Part of that is retraining the ones we have and working with the states to hire more. There are many volunteer health workers that we found, and we're engaging the states one by one and the subnational units, including local governments, to say, how do you hire? And these are some of the incentives that we bring to the table to help you as you increase your workforce. Thank you.
Okay, thanks. Let's go over to Professor Samuel Oluokere. I believe he's up and run as well. He also joins us via Zoom. Yes, there you are, Prof. And you've heard the comments so far. Let's get your own perspective to all of this.
Yes, sir. Thank you very much. Hope you can hear me.
Yeah. I think we lost that link there. We'll try and re-establish links with Professor Oluokere. But let's get back here to the NHFS project coordinator of the National Bureau of Statistics, Dr. Abolade Surajudeen. Again, the JAPA syndrome has hit health sector real hard. But again, as Dr. Aina says, you can't stop people from taking decisions to better their lot. What you can do is improve what they can access here, and hopefully re-attract those who've left. When you look at what do the statistics say when you look at the numbers that have left? I've heard people argue and say, well, it's not anything to worry about, because if we have many Nigerian professionals going out there, they're still going to come back and bring such expertise.
Actually, initially in the 80s, 90s, we were talking about brain drain, about those who are JAPA. But now, from the 2020 downward, upward, now we are talking about brain gain. Because there are a lot of gain that are coming in from those who have left. Those who have left the country for these more developed countries sometimes come together as a consortium of professionals to bring back to the country. We have had about a series of surgery that has been conducted free of charge. We have had about a lot of remittances that is also coming from these migrants that have left the country. But just as Dr. Anel has said, the present government they are doing a lot to rescue this JAPA syndrome in terms of putting all the necessary infrastructures and remuneration that can enhance the functionality of these health workers. And with the kind of information I'm even getting from Dr. Aina today is mind-blowing, because most of us don't know what is being done at the level of the government. It's until we have forum like this that we hear what is being. And if you look at the report that came from Oka, the facility that was being showcased there, the matron said that we have solar inverter. There is no light now, but what we are using presently is solar. It shows the commitment of the government.
Well, yes.
Okay, very good. When one reasons on the JAPA syndrome, I would like to relate it to what we call the pull and push effect. The pull and the push effect must be understudied by the government. What is really pushing people out and what is pulling them from other parts of the world. So by the time we look at that, we will now be able to address these challenges, headlong. Nevertheless, the government has been doing a lot to ensure that this Jabba syndrome, as it concerns healthcare workers moving from Nigeria to other parts of the world, is actually regulated. On that note, the Embassy of Health and Wellness, we went to 112 fraternity schools across Nigeria with a view to strengthening the workforce, with a view to strengthening health education and what one could call empowerment, or enablement. So what that supposes to mean is that we reason that we can't stop people from going to any part of the world that they choose, but we can comfortably increase the number of production, and then we went to unity schools to catch them young. And then when we got there, we realized that we came with pre-test, the exams and the post-assessment, where for the students, reviewed the challenges that they've always had, not getting to their desired courses or not wishing to study healthcare courses anymore. So what did we do? We found out that the social media has been there. Some of the influencers have been telling them not to go for healthcare courses, that AI will replace healthcare workers. And then we also found out that lack of peer-to-peer engagement, unlike what happened in our time, where a teacher would leave the class, students would gather to brainstorm. Even when they get home, they would do the same. And in the recent time, you realize that when they get to school, they discuss what happens on social media. And when they get home, they continue to use their parents' phones to surf the internet. And then only God knows what they are interested in. Then we also found out that they had lack of concentration. They also complained of peer pressure, that society is becoming monetized. What did we do? We decided to look at all these challenges. We gathered them together, educated them on it. And one of the things that we ever did was to write books, 5 books that will help them to navigate and then to overcome these challenges with a view to producing more. Just like Dr. alluded, that the federal government is actually doing a lot to ensuring that the number of people produced from medical schools would always be far more than what we've always had. So we decided to go to these particular schools, and that was exactly what we did, and we're happy that we did it. And then we are going to replicate the same in command schools and in police schools, and subsequently in all the schools across Nigeria. So that actually explains what the government is doing. But I would want us to continue to look at this pull and push effect so that we can continue to find out what are the reasons people are leaving. Is it incentive? Is it remuneration? Whatever it is, so we can actually address this workforce shortages, which reflected in the NHFS in ways that I looked at it and I was not very comfortable. Well, looking at what we're putting in place, we believe that looking at the future, we believe that the Nigerian healthcare system would get to that stage where it will be robust, to be equitable, and capable of addressing these challenges.
All right. Let's try to see if we can re-establish links with Professor Samuel Olowokere. Prof, sorry that we lost the links there, but perhaps you can get back up and let's hear you. We're just about to make a contribution. Yes.
Good evening, sir. Good evening, sir.
Good evening, Prof. Go ahead, please.
Oh, thank you very much. I thank you for inviting me for this very important program. The issues have been well discussed. I've listened to everybody while discussing the issues. But I want to add my point. What is the government doing about community-based health insurance scheme? The universal health coverage needs to go beyond the National Health Insurance Authority, which is mainly targeting those in the formal sector. So I think the government should strengthen our community-based health insurance scheme and the free health services being given to the populace. That one is also quite good, but the drugs are very, very expensive now. And a lot of companies are leaving Nigeria. Can the government do something to bring them back? There also has to continue remuneration that be raised earlier. What of the people that are going? Why can't the government find out why and what to do to make them remain? Because even when you train doctors, nurses, other health workers, they tend to go away to where they feel things are better. Those are my contributions to me.
All right, thank you so much. Unfortunately, we couldn't get to see you on, but at least we heard you loud and clear. We'll still work on those links and see. But I believe that at this point, Dr. Aina would like to quickly respond to that, because you've raised certain basics, especially the question about community-based health insurance scheme. You say should go beyond the NHIA. And of course, efforts to capture the huge informal sector into the insurance. Dr. Aina?
I think when you look at the history of health insurance in Nigeria, I think over the last, up until a year ago, over the last several years that we've had the insurance program, I think in aggregate, we were only able to cover about 16 million people thereabouts, if I have the numbers correct. Over the last year alone, the NHI has been able to add another 3 or 4 million people. Now, that's not nearly where we need to be, but you have to go step by step. The first step is really redefining what is health insurance, what should be covered, what are the parameters that should define what is sustainable insurance in Nigeria. You know, who's the vulnerable person that should benefit from the vulnerable group, and what should private health insurance also cover. There's a lot of initial thinking and design work that NHIA has done there. And then the next thing is then working with the states, you know, and the federal government, the parastatals, the ministries to cover all of the formal sector. And then the next phase of that is moving into the informal sector. So I do assure you that you will see some movement. There's some activity already going on there, but I think the first thing was to even capture the low-hanging fruit, which is the formal sector. And NHIA will be moving on to the informal sector. Prof did mention something about commodities as well, and the cost of medicines, but also the exit of manufacturers. I think, in fact, you know, in the middle to late of 2023, a few companies did announce that they were leaving, but I'm also glad to inform you that, in fact, one of the experiences we're having now is that over the last 3 to 4 months, several of the same companies have come back to say, actually, we didn't say we were leaving, we were just rejigging our model, we want to come back. And new companies, if you have been following the activity of the President's Value Chain in Health initiative, you know, there's been a lot of things around policies enabling environments, but also, you know, engagements that are bringing local investors. We're really foreign investors to come and invest locally and produce locally to lower cost of medicine. But even while that is being done, I think if I can cite a number, there are some 50 plus different pipeline deals that PVAC is working on right now and is raising financing for foreign manufacturers that want to manufacture locally health commodities, medicines, medical devices, and other health-related products. So I think that's a major development. Now, just very quickly, in the interim as well, before that you start to see that production, the government, the president, has specific interventions around medical relief, where, you know, pooled procurement of medical products and medicines are being done and being distributed, and you will start to see that. There was some of that in 2024 budget, but I can tell you that there's a large piece of that is already being inserted into 2025 budget, where a lot of the medications that affect common ailments, diabetes, hypertension, you know, will be provided free for the most vulnerable Nigerians. That is in addition to maternal health commodities that are anyway provided free in many of the facilities. So,
all right, at this point in time, we'll take a short break. When we return, there'll be more on the issues at stake, and hopefully our phone lines will be open, and it means you can join in the conversation in the studio. So stay with us on NTA Tuesday Live. We'll be back shortly.
From the Atlantic across the savannah to the Sahara, we rise, a land of the free, we know they tire. We dream great, our spirit is undying.
Resilient, rooted like palm tree, we sway in colors, with undying demand, we make solutions, we ignite passion, yeah. Ethnicity is unique, we are more than just a nation.
We are Nigeria, strengthened in unity, we know they carry lives. We are Nigeria, together lift the tree of a land with great destiny. We are Nigeria.
I am the Real Nigerian. Brought to you by the National Orientation Agency, NOA.
The federal government of Nigeria warns vandals of national assets, electricity transmission towers, cables and other facilities to desist from this act of sabotage. Vandalism is a serious crime punishable under the law. Vandalizing electrical equipment will affect millions of Nigerians, including your loved ones. Remember that national assets belong to all of us, hence the need to protect them. Report all cases of suspicious movement around electrical facilities to security agencies. When you see something, say something. This message is from the Federal Ministry of Information and National Orientation in collaboration with the National Counter-Terrorism Center, NCTC, Office of the National Security Advisor.
NTA Tuesday Live, a network issue-oriented innovation talk show.
Thanks for staying with us. Still about the National Health Facility Survey. Well, this is a segment where the phone lines will be open, where you can get to join in the conversation in the studio. The numbers to call will be on your screens. We advise you take advantage of those numbers. And we say this every Tuesday. If you're calling in and your call gets through to the studio, do us a favor, turn down the volume of your TV set to avoid the hurlback or the echo. And we encourage you to keep those calls short, straight to the point, and simple. And also not to worry too much about the greetings. A simple hello would do. Well, we'll start off with another of our reports. This one is by Musa Abubakar.
We can see all the stakeholders with us.
Key findings reveal significant gaps in the availability of essential drugs, basic medical equipment, and maternal health services. Only 35% of health facilities in Nigeria have essential drugs, with primary health facilities lagging behind at 34.3% compared to 50.6% in secondary facilities. Similarly, just 31.4% of facilities have basic medical equipment, with the secondary health facilities faring much better than primary facilities. When it comes to delivery equipment, only 40% of facilities have the necessary tools, further highlighting challenges in maternal health readiness.
The service delivery indicators focus on assessing primary healthcare service delivery, ensuring that the monitoring process promotes greater accountability, enhance governance, and facilitate more targeted interventions for improved healthcare outcomes.
Family planning commodities are also in short supply, with male condoms available in just 20.5% of facilities, injectables at 19.5%, pills at 18.5%, and implants at 17.8%. In terms of antenatal care, 79.7% of health facilities provide these services, with secondary facilities leading at 86.2% compared to 79.4% in primary facilities. However, the survey highlights significant shortcomings in postnatal care, which is available in only 17.5% of facilities.
Health professionals, policymakers, and partners need to work together to address the menace and issues around our health system.
I feel challenged and in some instances a little bit depressed that we're still at this level at this point in time. When we look at level of essential drugs available at the basic healthcare facilities that most Nigeria goes to, about 30%.
These findings underscores the urgent need to address critical deficiencies in Nigeria's healthcare system, especially in primary healthcare facilities, to ensure better service delivery and improve health outcomes for the citizens.
All right, that report by Musa Abubakar. So back to our guests on the program. Let's see if we can get back to Dr. Nuhu Solomon Ayegu. Is still with us.
Thank you very much. I think I'm enjoying the contributions of speakers in this today's discussion. Like I mentioned earlier, my emphasis is that we move away from policies and principles put in place by government, which there is no effective implementation. Now, government of the day is doing a lot to improve our healthcare delivery system. But unfortunately, there are factors that are there that are serving as bottleneck. There are clogs in the wheels of progress of our healthcare delivery system in the country. For example, corruption. Now, if government has actually put in place adequate budgetary allocation to healthcare system, and we're hearing lots of trillions of nairas allocated to these to the improvement of our healthcare system. Unfortunately, at the end of the day, drugs are procured, equipment are also procured, but they are diverted to private facilities. Okay, or the drugs, the monies are being allocated, but those things are not procured to be given to the various health facilities that are there in the country. Then, how then can we be effective in our healthcare delivery system? When we are looking at the challenges that we are facing in the healthcare, in the health sector in this nation, there are attitudinal problems. The attitudinal problems on the part of the health professionals, the administrative bottleneck. You get to the hospital because of inadequate health personnel, you will discover that it will take a longer time before the person that a patient that is supposed to get an urgent attention before it's attended to. Be passing through all the administrative bureaucracies, before you know it, the person pack up. So all those things have to be carefully looked at. Again, the unprofessional behaviors of some health workers is another challenge. You know, I think there was a time I was on the NTA like this, and we discussed on this matter, where the health workers now have a very nasty, bad attitude towards the patient or the clients, where some of the nurses will be insulting the patient that they are to attend to, or some of them will be bullying them. All those things are not really helpful. Therefore, there should be training and retraining of the health professionals so that there can be strict adherence to the codes, the ethics and the etiquettes of the medical profession, because all these things are not allowed in medical practice. But as of today, all those things have been neglected. Then again, on the part of some of the medical personnel, there is no empathy, displayed by the health workers. Somebody that is dying that you are attending to, instead of being empathetic and attend to that person professionally, you don't care. Before you attend to the person that is brought before you, you are attending to other personal needs. These are challenges that we need to actually look at. Them. The issue of discrimination is also some of the challenges that I can classify under the attitudinal problems with the health professionals. The discrimination in the sense that there are the patients that come to the health facilities, there are some of them, those that are within the high social class that will be well attended to. And then the poor are not attended to very well. These are serious challenges that we need to critically look at so that there can be improved healthcare delivery system in the nation.
Okay, thank you, Dr. Ayegu. But as we bring in Dr. Abaradi Surajuddin, I'd like to add a bit here too, and that has to do with what he's just spoken about, which is diversion of drugs in some cases where this has happened. And of course, he's highlighted the lack of professionalism of health care givers in some cases, but these are also being dealt with here. So as you go into analyzing what Dr. Ayegu has said, I'd like you to also keep in mind the location of health facilities. Now, we've seen, not necessarily the federal government, we've seen governments, for instance, set up tertiary health institutions where they could as well revamp primary health institutions. And in such cases, you've seen tertiary health institutions playing the role of, the first port of call, dealing with things that ordinarily should be dealt with at basic health institutions. How has that affected this as well?
Thank you for this question. Actually, the issues that was raised by Dr. Nuru as something that are being confronted in the system, and with all the policy that is coming up from the government side these days is trying to address this issue. Let's just take the issue of the artisanal case of health workers. If you go to, let me take for instance, National Hospital that I personally use, there is this service pack that you have there, that in case that any health workers did not address your issue well, there are phone numbers to call. You call these phone numbers, which I can attest to it in National Hospital. If you call that service line and make that report, complaint to that number, immediately the officers that has done this will surely face the book. The issue of procurement also has been addressed by the government. That's why there is nothing there is no budgetary allocation that has to do with procurement that does not pull through the period of procurement.
Okay. Let me ask you to just hold on a while. We have the first caller on the line. Teresa calling in from Abuja. Hello, go ahead.
Hi. Christopher, how are you?
Yes, go ahead, please.
Please, I want to recommend about what the procurement just said just now about the doctors and the nurses. Yes, it's right. Because when a patient is in the hospital, and you see the way the doctors talk to the patient, or especially the nurses, are very, very rude to the patients. And once again, when you go to the general hospital, especially National Hospital and General Hospital, National Hospital number 1, number 2, you go to Asokoro or Metama, when you were talking to the doctors or the nurses, very, very rude. And you see the patient will be devastated.
Okay. All right. Thank you for that.
And one again, government should look into it again. When you're talking, the government did not give us they didn't give us any instrument to use for the patient, and you see they will be very rude.
All right, you've made that point, so I guess we'll respond to this, and
if they can look into it, like the way the other Dr. Abayo said now. If you look into it, you will see what is happening live.
Okay. Well, he's just also disclosed that there is a mechanism to get a feedback for those institutions, and he's even spoken about them. But thank you for calling in. Let's get the response here from this side of the program. Thank you, Teresa, calling in from Abuja. Right. Yes, Dr. Swed. Okay. You were just about...
okay. The issue of training and retraining is very germane. I can give you an instance from my office, the National Bureau of Statistics. In 2005, when we moved from the then Federal Office of Statistics to National Bureau of Statistics, we were giving what is called management training, management change training. We had that in Lagos for all the staff of the Bureau. And this training really have a lot of impact in our attitude, in our behavior towards work. That's why if you come to the Bureau today, you will see something different from the belief of ministry worker that you always have. So this, if they have this training and the training, it will go a long way to help them.
All right. Well,
I think.
Oh, okay. We have. Okay, another caller. Abdullahi, calling in from Burning Kebi. Hello. Are you with us? Okay, seems we can't get Abdullahi on the line. Okay, I'm just trying to call back. Hopefully we'll be able to accommodate your call as we go on. Okay, yes, let's hear you, Dr. I know.
So I'd like to highlight that one of the pillars of the health sector blueprint that the coordinating minister, Mohammed Pate, is leading is really, in fact, the first pillar is around the governance and accountability of the health sector. And you will find that that trickles down in all of what we are doing, the many different agencies and across the Federal Ministry of Health. So part of that is making sure there's transparency and visibility in the way we're doing things, whether it's procurement, but also service delivery and things. But part of that is also making sure that we're responsive and accountable to the people that we're trying to serve. On the primary health center side, for example, we have launched a dashboard that every Nigerian, you can go to it now and see, depending on where you are, which PHCs are near you and what services you can access there, how many health workers you should find there. And if you get there and it's not what you expected to see, there is a mechanism for you to give us feedback, either call or just log it in there. The website is https://.nphcda.gov.ng. Now, there are also mechanisms where citizens can engage at the Ministry of Health through phone lines and call centers. Now, you talk about health worker attitude, diversion of resources and health worker attitude. Again, part of the governance framework that we're using is really doing what the government can do, which is maybe resources available, but also put in measures to minimize the risks or the impact of theft. So there are many things we're doing. We're using technology in our BHCPF program. We're using performance and financial management officers and things like that. Right. However, I'd like to say, Cyril, before I go, that this is also where individual and collective responsibility comes in. I think, government can train people, government can legislate, but you see, the health workers, the individuals who are stealing these commodities, who are stealing this, they are our brothers, our sisters, they are your wives and your mothers and Nigerians like the rest of us. And I think it is important that we don't put everything on government to regulate the behavior of people. You can legislate, but I think we need to also go back to holding one another accountable as members of a community.
Okay.
Thank you.
Let's get back to the phones. We have Jude. Thank you, Jude, for staying on. Been on for a while. Jude calling in from Abuja. Hello.
Thank you.
Right.
Good evening, everyone.
Good evening. Right.
The issue of our public health workers is a very serious one. I speak not because of this program, but I have been thinking of where I can channel some of these complaints, which I have personally witnessed. One, the first instance was when I was a monitoring and evaluation officer with a facility. The conduct of the public staffs to these patients, it's because most times some of these patients, they are timid. Sometimes when they walk into facilities, they are even scared to walk into an office or to even ask questions. And most times you see these public officers ignore them. Most cases, a case of maybe the brother and the ward needing a medicine needed to be attended to, but maybe in the OPD need to get a card. You see how they treat them, they walk past them. 1 minute can cost a life. The last experience I had, my wife gave birth a few months ago. If not for my person that I am a very outspoken person, but the general activity of this facility, it is alarming in terms of, okay, you have a woman that went through a CS to give birth. You bring her, you keep her in the wardroom there, and that is it. 24 hours of the day, nobody walks in to check on this person. No, the family members are there, that's okay, but it's not enough. The only thing they do is maybe morning routine. Someone comes and checks the drip, and then that is it. The drip sometimes gets finished, and if the patient is sleeping, the next thing is the blood flowing back up into this drip. Sometimes I will be the one to go to the other beds, trying to put it off so that the blood doesn't flow. So the attitude is alarming. It's not only to the healthcare, it's everywhere the public serving officers in Nigeria. They think they are God. They don't know what they've come to do. Their service to humanity is very important. So I think if this number, let me round up. These numbers that were spoken about that are there for calling, it should be in all wardrooms. It shouldn't just be in the reception or anywhere. If it's in all wardroom, I think it will be of a reminder to these workers that there is something, a number that can actually take me out of my job.
All right.
So therefore, they will do what they need to do. And it should not only be in the public facilities. It should cut across private facilities as well.
Okay.
So that is my own opinion.
Thank you very much, Jude. You also have highlighted that it cuts across. It's not just peculiar to the health sector. But again, those were the issues that Dr. Aina was earlier on speaking to, that you also need people to be accountable and to be responsible when they have a duty to perform. It doesn't really matter whether they're in government or in private sector. But at this point, let's see if we can get Professor Lou Okere. Is he back online, or can we get him?
Yes. Thank you very much, sir.
Yeah, okay.
Can I comment now? Yes, what the caller just said is quite true. I'm not defending the health workers, but I imagine what happened in the primary health care close to my house here at Oshogbo. Only one person on duty 24 hours. The fatigue setting. Some of them retires before they are replaced, and the retirement benefit does not come in on time. You train people, you employ them, they jumper abroad. That cut across everywhere in the country. So people are angry. Health workers are human beings, and when you don't get your retirement benefit, and you are just there working, serving the system, and nobody acknowledge you. I'm not defending the attitude, but we are, as I said, we are human beings. And then sometimes the religion is also affected. The delays that happen, especially when we talk of pregnant women, they go to churches, mosques, elsewhere, And when the churches and mosques could not do anything, they now send them, when they know the problem is going bad, that's when they send them to the facility. And when they get to the facility, the person there has been working round the clock, no replacement, nothing. So I think apart from giving phone numbers, government should do more. Government should do more by making sure that the place is well staffed and all the materials needed are provided. And capacity building, as somebody mentioned, one of the people sitting there mentioned that capacity building is very important. I quite agree. But also remuneration is very, very important. They should come in as at when they, because the truth is, if you treat health workers well, they will do their best. Because even people they are attending to are most of the time people in their neighborhood, in the same community, and they know each other when it comes to the primary health care level. They know, like, I have worked in the primary care setting before, and I know quite everybody in that community. And I remember taking deliveries, so many deliveries at Tigora, because we have the highest training in Nigeria. We have the highest training all over the world. I remember I knew virtually every house in that community, and people know me and respect me for it. So, but when I look back and I discovered that the way I was treated at the end of the day was not quite good, and so also others. Even I was lucky that some people, when we look at, no, I'm not talking of treatment from the community, I'm talking of treatment from the government, those in charge. And many of us actually jump, and why some of us to stay there, because this is our country. Okay. If we go elsewhere, wherever we go, we still have to come back, because the country has been good to us.
All right. Not
necessarily the government anyway.
Okay.
So I think both sides will be looked at. Okay. Not just punishment, but punishable things is good. But you also have to look at, maybe I'm suggesting that a primary health care agency should do a study among health workers. Why are they aggressive? Why are the health workers aggressive people to their neighbors? Why?
Okay.
Because abroad, when you go abroad, you see research every day on every topic. What is causing the fight between nurses and the patient? Or the patient and the nurses? Let me give an instance. Sorry, I'm taking too much time. Let me give an instance. I watched on television a situation in UCH, University College Hospital, Ibadan, where a Muslim woman brought her child to the intensive care, the children intensive care unit, and the woman happens to be in Puda, but UCH have a policy that every woman must not cover herself. There's issue of religion here, but do you know that woman was sent out because she refused to remove her Puda, and it was on national television. I was asking myself, this will not happen in Saudi Arabia. Why can't a woman remain in Buddha and still care for the child? I'm not a Muslim, but I felt for that woman. And they had to go to a private hospital where, from what the newsman said on that television, on that day, on that program, that they had to go to a nearby private hospital owned by a Muslim where a Buddha woman cannot care for a woman in intensive care unit, for a baby in intensive care unit. Okay. I think we should try and look at the situation and look for situations, for ways to solve the problem.
All right.
Look at. Thank you very much.
Okay, thank you. Well, you did mention, you asked a question which I'm sure Dr. Aina will respond to. You said why are workers in the NPHDA aggressive? And I'm quite sure that Dr. Aina agrees with that. But again, he will speak to the issues. Right?
I don't think he meant NPHCDA. I think we're very nice people that work at the National Primary Healthcare Development Agency. I think the comments are around frontline health workers and why they're sometimes not as nice, as we would expect them to be. I think it's a myriad of factors. I think we've talked about it's a very stressful job sometimes, and when they're understaffed and when they are also just under a lot of pressure, I think they're also humans. I think the way to help them is a number of things. One is to give them the capacity and the tools to cope with stress, to treat them well, remunerate them, but also make sure that they're adequately staffed so one person isn't overworked, and that's all of the efforts that I already said the government is pushing on. But I also do think that sometimes as well, you see, because I've been a health worker also before, I've worked in health facilities before, is that sometimes the perspective that you see from one side is very different. When you have to prioritize as a health worker, sometimes, the loudest patient is not necessarily the neediest. In fact, sometimes it's the one that is quiet, that is about to die, and that's the one you need to go to first. So understanding that everybody is important, sometimes you need to prioritize as a health worker. That said, I think the issues of health worker attitude and its impact on people's health-seeking behavior is very well documented, and it's something that we're addressing headlong through the training, but also through feedback mechanisms from citizens and accountability for our staff. I think also sometimes also just speaking up, if you are a more empowered person, also just weighing in and pointing out to people. Same way you do in the street when you go to the mall or the store and somebody is cutting the line or misbehaving. Sometimes just pointing it out and saying, "Mister, this isn't right," people will adjust their behavior. Right. Thank you.
Dr. Eze, you were going to
very good. One of the pillars of healthcare, as it concerns ethics, stipulates that patient should not be made a subject of suspension. Rather, they should be made a subject of protection. That being said, it's very important that healthcare workers are encouraged to take care of their clients, the patient, treat them in the best of forms so that they can have feelings for healing. It stimulates the healing process, and it goes a long way to encouraging more mutual understanding, and also enabling you to understand this patient, understand their situations in the best of forms. Now, one would also now say to oneself, is it only the healthcare workers? The answer is no. The issue of aggression is becoming a widespread thing across the world. Maybe it's more intense in this part of the world. Humanity is being lost, and people tend to think more of themselves than other people. Is that?
Hard times, perhaps.
Hard times, that's correct, Cyril. Then one would now say, how best could this be handled if it cuts across? I think one of the things that made it appear less in the olden days was the issue of etiquette being taught in schools, where people would, from the beginning, learn how to approach issues, approach people, and be well-meaning to the next individual. Like what happens in Japan. As soon as a child is born, he wouldn't go to school until he learns etiquette from home. And when he gets to school, the first thing that he will begin to learn will be this etiquette. And that would go a long way informing you why someone, appears appealing in that part of the world. And if you leave your possession anywhere, you're coming back to pick it. So these are the things we shall be looking at, not pinpointing one, a sector of Nigeria or one particular group of people or workers, because each time I go to places too, I face the same thing. I face the same thing, be it restaurant, be it offices, be it whatever, any facility. You realize that people are no longer welcoming. So I think it's one of the things the federal government would have to do at this time, maybe at the primary school level, to make policies around etiquette and ethics, as the case may be. And for the healthcare workers, always remember, don't make your patient an object of suspension. Make your patient a subject of protection.
Right. Well, a lot has been said about government interventions and policies to address challenges in the health sector. But again, I want to bring this up. Just as we begin to wind down, what role for the private sector where you find people, philanthropists from other parts of the world, take a lot of interest in addressing health challenges, in Nigeria particularly. And you ask yourself, where are the Nigerians of means and how much are they putting into this? Should it be just the government?
I think, if I may,
Yes.
I think in fact there are a number of ways that the private sector already plays important roles, but can play even more important roles. I think on the supply side, if you look at the data, a big proportion of Nigerians, more than half, receive their basic services from private facilities, either health centers, private pharmacies, or patent medicine vendors, and issues like that. That's kind of already a role. I think too often we think of healthcare as a burden, as a philanthropy object, but it's actually a business. In many environments, healthcare is in fact a major contributor to GDP. Health tourism is a major drain, has been a major drain even on the resources of Nigerians. So that's why the government is now trying to reverse that, to say if we can tap a proportion of that by building an end-to-end value chain in healthcare and bringing back some of the money that is going abroad to receive services, but also to procure commodities, that would be good for our economy. So from a service delivery perspective, there's a lot of role for private sector that they are already doing. But even on the insurance side, when I talked about the number of Nigerians insured, quite a substantial number, actually the majority are on private insurance. So people who actually procure healthcare, private companies play a role in that. Then there are all of the intermediaries, all of the facilitators, technology companies that build the data systems that you use in the health facility, companies that build systems and sell systems for remote learning and for remote telemedicine and a lot of other things. But even the manufacturers of the commodities that we're using, so that's big. Now, for the non-profit or grant-making donor aspect of things, I do agree that there is a lot of room actually for our local philanthropists to focus a bit more on health. I think we do get a disproportionate amount of inflows from wealthy non-profits or individuals from overseas. I think, so I do encourage people to engage. But when people engage, they should think of it also as an investment. And sometimes the yield is not in money, but it's in life saved, it's in health produced, it's in illness averted. So if you think of it that way as well, then it becomes a bit easy to see value in investing in health.
Right, Dr. Sirajuddin, we're winding down. So.
The issue of the private coming in, actually, looking at it from the perspective of the give back to the society in terms of the complaints, and not just complaints, those of us that stay in community where we can be of assistance to those within us. These are things that we do when we're growing up. We saw it practiced within our community. When somebody is sick, the whole community takes care of that. I don't know whether it's still operational then now. Like I have this Roach pharmaceutical company. There are things that they do give to the community then where they operate. They do in terms of giving out of drugs. Then also during the end of the year, there is this fun fair for children. It's like giving back to the community. They go a long way to assist, and not just assisting the individual, by implication they are also assisting the government, and all this help the society generally. So if we can go back to those stands, I think it will be more than the private companies thinking of just profiteering, not giving back to where they are making the money.
All right, and let's at this point now try to get guests on Zoom to make their closing comments as we wind down. Dr. Nuhu Solomon Ayegu, your final comments on tonight's program as we wind down.
I think we have been very exhaustive enough, but there are very important areas that we have not mentioned that I need to mention, so that even if we have enough time to deal with it today, another time we can look at it. Because when we talk about health facilities, there are diverse challenges that have been identified. And if all the challenges are not properly identified, then we cannot think of a profiling solution. According to Robert Schuller, a man that wrote a book titled Tough Time Never Lasts, but Tough People Do, he talked about IPDE, principles of problem management, identifying your problem, predicting what the problem will do if it is not solved, taking decision and executing. Now, one of the problems and the challenges of healthcare services is the problem of not having an organized and well-specialized waste management system. Take, for example, a patient or a client visit a health facility, maybe with a minor problem, maybe with a malaria case or typhoid fever case. But because of the unorganized way our health facilities are managed in terms of waste management system, he goes back with another problem, what we call nosocomial infections. You come with a little problem, you go back with a heavier one. Why? Because our facilities are not well equipped. We're supposed to have, most of our leaders travel to advanced countries of the world, and they look at what happened in some of these facilities that they have there. In any standard health facility, there's supposed to be a very good standard waste management system, whereby all the waste that are coming out from the patient, which are highly infectious, are to be well managed. Vis-a-vis establishing what I would call an incinerator, so that all this waste can be completely destroyed. This is a very important aspect we must look at. Then, as we try to assess ourselves and give ourselves a pass mark, we will not be able to do it correctly if we don't do it side by side with the WHO standard in terms of size of the hospital, in terms of the staffing in the hospitals, in terms of the availability of the different professionals, health professionals that are supposed to be in the health hospital, and then in terms of the number of patients per facility. All these things are the standard. Now, as we are discussing this, our decision makers, policy makers, should critically assess the state of our health facilities in the nation, and vis-a-vis try to assess, appraise, and measure it side by side with the WHO standard. Then on the final note, when we look at the various challenges, I try to classify them under attitudinal factors, patient-related issues, and then systemic problem. In the aspect of the patient have their own problem in regards to non-adherence to the prescription regimen. Most of the patients are having problems that are not well managed because they fail to adhere to the prescription regimen. In view of that is why I have been advocating for our health training institutions to be adequately catered for, so that different cadres of health professionals that are non-existent in our health facilities today are to be there. In a health facility, we're supposed to have health educators. The health educators also should be able to educate our patients to strictly adhere to the prescription regimen given to them by the pharmacists or the doctors. Okay. And on the final note, please, let the federal government still remove that issue of the dichotomy, try to cause a differentiation with the monotechnics and other tertiary institutions in the country. Imagine colleges of health science and technology that produce different primary healthcare workers that to take care of our rural populace. it is not being catered for, and that is up to today. There are serious gaps in terms of staffing of our health facilities. So the different health professionals are supposed to be there in our facilities are not available because there is a negligence on the part of government in the area of taking care of the colleges of health science and technology and being able to have the facilities to be able to train different health professionals and to be able to manage our facilities so that we can carry out a holistic primary healthcare delivery system, not a lopsided type that we are doing. Thank you very much.
Well, thank you very much, Dr. Nuhu Solomon Ayegu, immediate past Provost of the College of Health Sciences and Technology, IDA in Kogi State. Thank you so much. And let's go over to Professor Samuel Oluokere for his closing comments as well. Prof.
Thank you. I just want to thank you and the NTA for inviting me for this program. And I think everything has been said. In fact, most things have been said. But there is something remaining. The retirement benefit of workers. The pensions, whether it's contributory or the traditional pension scheme. I think government should do something about it. A lot of workers, whether health or non-health workers, are retiring every day and they are suffering. Some of them are even working to death. And imagine somebody over 70 still working as if instead of resting, he still have, maybe he has some things to do and he has to keep working and working and working. We see it every day. And when we talk of corruption, people think of tomorrow, and that is why some people are corrupt. It is not a way of defending corruption, but it's a reality. My provost and everybody sitting down there will retire one day, and if they do not have their benefit, retirement benefit, people look and make jest of them that they've served the system, and at the end of the day, they are still suffering. So I think government should take, our government has done well, but they can do more.
All right.
They can reduce corruption by tackling, making sure people get their benefit as at 20. Thank you.
Thank you so much, Professor Samuel Oluokere of the Faculty of Clinical Sciences of Bafemi Awolowo University, Ile-Ife. And back here to the studio, quick closing comment from Dr. Eze.
Very good. The Ministry of Health and Social Welfare with National Bureau of Statistics have done noble in bringing forth the NHFS. And a visual examination on this findings would always reveal that we're not where we should be. But I think they've given us all the things that we needed to have known. The problems have been identified. It's now left for us to bring it closest to chest so that most of our decision making, policy making will be informed by it. And it will also enable us to prioritize very well. And as it concerns the gaps, encouraging us to get the public-private partnerships on board so that we can address some of these things, we should have long been addressed. If you remember in year 2000, a lot of African countries came to Abuja, encouraging 15% of the budget, as it concerns health, being one of the things that should have long started, but it hasn't started up until now. So we know that whatever the government is doing or policymakers are doing with a view to bridging these gaps might not be very easy. Because if we would look at the 15% since 2000, that supposes to mean that we're going to talk about 15% in 24 years. Okay? So that's why we're encouraging the public-private partnerships, well-meaning people across the globe, encouraging our international partnerships to come on board to ensure that this is a collective effort, because healthcare is equal to science, solutions, and solidarity.
Right.
Thank you very much.
Thank you so much, Dr. Chimele Eze, and Dr. Mia, the CEO of the National Primary Healthcare Development Agency. One final word from you regarding faith in primary healthcare in Nigeria, especially in these difficult times.
I think just to say, first, to thank everybody for what I think has been a good conversation, but also thank NTA for the opportunity to share our perspectives. I think I'd like to just say that President Tinubu has committed to delivering for Nigerians access to good quality basic health care in the time that he is here. He has assembled a team who work day and night and are very committed. So, from the ministers, the coordinating minister and the minister of state, to all of my colleagues in the agencies and even some of the civil servants that work with us, I think there's been a real orientation towards really trying to deliver this. It's going to take a bit of time, but we have made concrete progress, many of which I have highlighted tonight. If you look at funding, we may not be at 15% yet, but I can tell you for a fact that between 2023 and 2024, at least at the federal level, the health sector budget was tripled, at least in Naira terms. That's unprecedented, frankly. That's in addition to several development funding that was attracted by the sector, billions of US dollars. That is fueling a lot of these interventions that I'm talking to you about in partner. The states are also putting in more money, as we can see, in some of the things that you have highlighted here. I think, we are starting to see, the benefits of some of these investments, and I think Nigerians will start to feel the impact very soon. So I urge for patience, I urge for ownership, participation, and responsibility. It used to be that when I was young, for example, you would go to the health facility and check in on them and volunteer and help them as well. So there are many ways that Nigerians can participate. So just to say that the government is committed and we're working to deliver health for Nigerians, and we ask Nigerians to keep faith, give us feedback, let us know how we're doing, but also be supportive and let us go on the journey together. Thank you.
Right. And it is on that note we must leave this conversation and thank all our guests and also for those who called in and participated. So thank you once again. Next week we'll be back with NTA Tuesday Live. I'm Cyril Stober. Bye for now.